All right, it's 6:30. We're going to go ahead and get started this morning. It's my pleasure to introduce Dr. Piper. She's this year's West Coast Collaborative visiting professor. So just for some background, the West Coast Collaborative, it's a partnership between OHSU, UCSF, UC Davis, Stanford, and us. And it was created to promote faculty development among junior and mid-career faculty across the 5 institutions. And so this is a program sponsored by Dr. Pellegrini's Endowment for Leadership Development. And so we thank Dr. Pellegrini for his generosity to allow this event to happen. Dr. Piper is an associate professor of surgery in the Division of Plastic and Reconstructive Surgery at UCSF, where she also serves as medical director for cancer reconstruction, cancer reconstruction, and the program director for the microsurgery fellowship. She earned her medical degree from the University of California, Irvine, completed her plastic surgery residency at UCSF, and went on to complete a fellowship in microsurgery at the University of Pennsylvania before returning to UCSF as faculty. Her main research interests are in oncologic reconstruction. She has authored more than 80 peer-reviewed publications in leading plastic and reconstructive surgery journals, and has presented her work nationally and internationally. Please join me. As part of the Western Collaborative visiting professorship, she met yesterday with our residents, fellows, and faculty for a thoughtful and inspiring roundtable discussion, sharing valuable insights on academic growth, leadership, and mentorship. Please join me in welcoming Dr. Piper this morning as she shares with us her insights in the relationship between the microbiome and implant infections.
Well, thank you guys so much. It's truly an honor to come and be here and be presenting my work with you. This is actually the first time that I've presented it all collectively. And so any feedback would be greatly appreciated. This is very much a growing and developing project. So yes, my title is Understanding the Relationship Between the Microbiome and Implant Infection. I have no disclosures. And then Dr. Inaba kind of stole this slide, but I was going to tell you a little bit about me. I was born in Tucson, but then I was actually raised in a very remote town in Northern California. And I say that I'm from Ukiah because Ukiah is the big town, but I was actually from Redwood Valley. And when we moved there, we had no electricity, we had no phones. I didn't know what really internet was until I went to college. And so it's kind of strange now in this modern day when tech is everywhere. And then in between college and medical school, I spent 2 years at the Diabetes Center where I did basic science research, and this was a very formative experience for me. And now I'm back from Penn to UCSF, where I'm based at Mission Bay, which is our cancer hospital. Like Dr. Inaba said, my practice is essentially 100% cancer reconstruction. The vast majority is really breast because breast is so prevalent, but I also do orthopedic oncology, urology, gynecology, a little bit of skin, and sometimes I help with some of the transplants. I have an amazing clinical research team that some of the members are featured in the upper corner, but really they have helped make this project possible. As Dr. Inaba said, I'm the medical director of cancer reconstruction. I've been in that position for a couple of years. And then last year, I became the Residency Associate Program Director, where my kind of specialty within that is assessments and wellness, which I've learned is quite challenging. And then this past year, I became the Microsurgery Fellowship Director. My real introduction to research was in between college and medical school. And this was when I spent 2 years at the Diabetes Center. And I worked with Dr. Allison Shu, who is a basic scientist, and her lab focused on understanding the relationship between energy balance and glucose homeostasis, in particular with regards to the melanocortin system. And Dr. Shu impacted how I approach research. She always said you have to start with a question, and then when you're trying to answer that question, you have to tell a story. Once I began residency, I was fortunate enough to be taken under the wing of Laura Esserman and Ann Pellet, and they were incredible mentors. And mentorship, I think, is so important as you're going through and trying to figure out what you want to do with your life. But they really got my basis for research starting in breast reconstruction outcomes. Then between my 3rd and 4th year in residency, I worked with Dr. Spitani and Dr. Munster, who was a medical oncologist who ran phase 1 clinical trials. And it was during this year that I designed my first randomized controlled trial that was a total flop. Like, we enrolled one patient and it didn't even follow through. But I learned a lot about how to think about forming a trial. And this research year really led to my greater interest in infection and capsular contracture following implant-based reconstruction. And with that brief introduction, I wanted to delve into my current research, but I recognize that probably most of you in this audience are general surgeons. And so I wanted to give a brief overview of breast reconstruction so that you can have a better contextual understanding. This is what I typically tell patients. Their options for post-mastectomy reconstruction can fundamentally be broken down into three categories: no reconstruction, implant-based reconstruction, and autologous reconstruction. And for the purpose of this talk, I'll just focus on the implant-based reconstruction. We either do it in one stage or two stage. So they could have a mastectomy and an implant placed, that's called direct to implant, or they can have a mastectomy and a tissue expander is placed. And once the skin has had time to heal, then the tissue expander is removed and the permanent implant is placed. And so we call that two-stage reconstruction. So just throughout this talk, I say direct to implant versus two-stage. And then as of 2022, the American Society of Plastic Surgery published reports about the rates of breast reconstruction. And we can see that in the US, over 150,000 breast reconstructions were performed. And the vast majority are really implant-based. So it is a very commonly performed procedure in the United States. The majority are still two-stage reconstructions, but the number of direct to implant is rising. And then the other kind of branch point within implant-based is where the implant sits, whether it's above the muscle, called prepectoral, or below the muscle, called subpectoral. And I'll show you some schematics of that so you have an understanding. So first, this is subpectoral reconstruction. With subpectoral reconstruction, the inferior attachments of the pectoralis major are released, and then acellular dermal matrix is used to create this sling along the bottom to help hold the implant in place. Ultimately, that acellular dermal matrix incorporates into the overlying skin envelope, and it's really the pec major that's kind of over the implant. And some people think it can be potentially protective. Prepectoral implant-based reconstruction is where the implant sits on top of the pectoralis major muscle, so in the normal native breast anatomic plane. And in order to kind of hold the implant in place, you often have to use acellular dermal matrix to secure it in place. So a larger piece of acellular dermal matrix is used with prepectoral reconstruction. Now, implant reconstruction is plagued with complications. And I'd say the complication that really destroys my life are these rates of infection, okay? And then the other complication is capsular contracture. So infection, they're reported in the literature, the rates have been anywhere from 2 to 30%. And to put that in context, a woman who just has a breast augmentation, those rates are usually like 1 to 5%, okay? And so we know that the infection rates are impacted by radiation, tobacco use, and diabetes. Capsular contracture is when scar tissue forms around an implant. It's normal. The bodies should form scar tissue, but in some women, they form this excessive amount of scar tissue that causes pain and distortion of the implant. And there's various factors that are thought to contribute, but potentially the plane, so whether it's sitting on top of the muscle or below the muscle, whether or not ADM is used, what type of ADM is used, history of radiation, and then if they've had a prior infection. But for the purpose of this talk, we will just focus on implant infection today. So if a woman has an implant infection, it can cause a number of different problems. One, it can delay their adjuvant chemotherapy, radiation therapy. It leads to unplanned hospitalizations and reoperations, which really causes significant costs to the healthcare system. It also causes patients psychological distress. They never know when it's going to happen, and it can be very disruptive. Many of our patients have young children, and then they have to be in the hospital for days, not really know what's going to happen. And finally, prolonged antibiotic use leads to antibiotic resistance and a disruption in the gut flora. So with most implant infections, culture data is relatively limited. Staph and Pseudomonas are the usual culprits for breast implant infections, and we empirically cover for them with IV antibiotics when patients are at risk for implant loss. But as a result, operative cultures are often negative at the time of washout and explantation. So that highlights one of the many limitations of culture data and also potential application for microbiome science. So what is it about implants in the setting of reconstruction that makes them have such a high infection rate? Well, it's much higher than other implants like knee replacements, for example, or implant augmentation. And so these are kind of the known risk factors. We know that sometimes after mastectomy, there is very poor perfusion to the mastectomy flap. And that can cause mastectomy flap necrosis and delayed wound healing. And that is a clear pathway for bacteria to then enter the implant and seed the implant. Many of our patients are on neoadjuvant and adjuvant therapies like chemotherapies, immunomodulators. They've been radiated. And so it puts them in somewhat of an immunocompromised state. Our group has shown that if a patient has had an axillary lymph node dissection, they have impaired lymphatic drainage and are actually at increased risk for infection as well. And then finally, if they have a seroma or a fluid cavity around the implant, that potentially can get seeded. There's really wide variability in the administration of antibiotics after mastectomy with implant-based reconstruction. And some surgeons just use the antibiotics in the perioperative period, like 24 hours around it, but others might use it for weeks, for example, until the drains come out. And then there's also really wide variability in the type of antibiotics that surgeons are administering. So our research group investigated whether prolonged antibiotics reduce the incidence of surgical site infections through a pooled relative risk analysis. We compared patients who had either received less than 24 hours or more than 24 hours of antibiotics and the risk of surgical site infection and implant loss. We found that prolonged antibiotic use did not have a statistically significant effect on reducing the infection or implant loss rates. But this study did highlight the paucity of randomized controlled trials investigating implant-based reconstruction. So in conjunction with this previous study, we also asked, when do most implant infections occur? We pooled our data with the University of Rochester and divided periprosthetic infections into early. So early were infections that occurred within 30 days from surgery, or late cohorts. And those were infections that occurred more than 30 days out from surgery. Okay, so then we found that there was an overall infection rate of 14%. Okay. But when we looked at when the infections occurred, about 40% occurred within 30 days from surgery, but 60% occurred more than 30 days out from surgery, with the mean time to infection a little over 2 months. So we also found that those patients who had late infections were more likely to be smokers and diabetes, and that we more frequently found gram-negative bacteria and antimicrobial resistant strains of staph in those early infections. We also found that patients who had late infections were more likely to lose their implant. And so given that most databases only collect outcomes for 30 days, we're likely grossly underreporting the incidence of infections. And then we also concluded based on this that those late infections, they likely have kind of unique pathology and unique microbiology compared with early infections. So that led to my question, well, why do these late infections occur? And early infections, we said, right, they can be easily explained. There's problems with wound healing. There's an easy direct pathway for the bacteria to enter. But what about those patients who are totally healed and then develop a random infection out of the blue, like months later? Why does that happen? Well, this is where the microbiome might play a role. What is the microbiome? It is a unique composition of organisms that are present in a microenvironment. And studies have shown that differences in a patient's microbiome or in a person's microbiome play a role in regulating the local immune system. Metagenomic studies have demonstrated that the host microbiome interactions can impact health outcomes, and microbiome studies recently have become a very prominent field of research. I need a coffee sip. So there are several ways to assess the microbiome, but the two most common ways are 16S rRNA sequencing or shotgun metagenomics. Okay, so I'm going to kind of give you the overview in a nutshell. With 16S rRNA sequencing, a hypervariable region or portion of the bacterial 16S gene is then amplified. This technique allows processing of a very large number of samples and is more cost-effective, relatively, but it had limited taxonomical and functional resolution, really. Now, shotgun metagenomics, with that, the entire DNA within a sample is amplified. So you end up with lots of data. But the problem is it's incredibly expensive. and it's at risk for contamination. And in order to actually process it, it's very, very complicated statistics. So given the relative affordability of 16S rRNA sequencing, it's most commonly used and it's really considered the gold standard. In this schematic, you can see how that 16S rRNA sequencing targets that 16S ribosomal RNA, and that's specific to bacteria. And then through PCR amplification, it enables identification of various bacterial genus within a sample. Now, the diversity of the microbiome can then be further evaluated based on alpha and beta diversity. And throughout this talk, I'll go into alpha and beta diversity more. So alpha diversity is representative of a species richness or diversity within a sample. And so it's represented as the number of operational taxonomic units, so OTUs. Shannon Diversity Index is a way to measure that richness and evenness within a sample. Beta diversity represents the difference in diversity of species between samples. Okay. And so the total number of unique species within each ecosystem are then compared, and the Bray-Curtis index is then used to measure the diversity between samples. So recently, there's been growing interest in the relationship between the microbiome and surgical outcomes. And this was a systematic search which was conducted in 2017. And they only included studies that looked at postoperative complications after GI surgery and also looked at the microbiome of the gut. So they included 10 studies, 677 patients. And in all of these studies, they identified that there were changes in the postoperative gut flora after surgery. They found that there was an increase in potentially pathogenic bacteria, and then a decrease in what are considered protective bacteria, so a decrease in lactobacilli and bifidobacteria. They also found that in patients who had been administered preoperatively probiotics and symbiotics, that those patients had lower infectious complications, they had a faster recovery of bowel function, and that they had less postoperative cramping and diarrhea. Now, this study was just published in 2025, and it really expanded upon the previous study. So it's a systematic review that's, again, looking at gut dysbiosis and surgical complications. They included 30 studies and over 2,500 participants now. And the overall trends seen included decreased microbial diversity postoperatively, decreased number of beneficial bacteria, and increased pathogenic bacteria in relation to patients who had surgical complications. So they created this schematic that really highlights the intricate interplay between gut dysbiosis and surgical complications. So when there's gut dysbiosis, you have a decreased number of beneficial bacteria. You have an increased number of pathogenic bacteria, which then can lead to postoperative complications, starting with postoperative diarrhea, which then leads to a disrupted intestinal barrier and ultimately surgical site infection. Okay. But while the disruption in the gut is strongly associated with adverse postoperative complications, the distinction between correlation and causation really is not clear. Okay. And so a leading hypothesis suggests that surgical reconstruction disrupts the gut microbiome, and that promotes gram-negative bacterial overgrowth. Then the subsequent release of lipopolysaccharides triggers this inflammatory pathway that then compromises the mucosal barrier, and then it facilitates pathogen invasion into the submucosa. And so it perpetuates this systemic inflammation. The microbiome has also been implicated in the development and progression of different tumor subtypes. So it's been demonstrated that the microbiota play a fundamental role in the immune system development, as well as tumor immunity, and also that gut microbiota are involved in chronic inflammation. So over the past 10 years, the interest has grown in the potential relationship between breast cancer and the microbiome. And this study came out of a collaborative effort between UCSF and the other UCs, where we looked at patients who had breast cancer, DCIS, and then healthy controls, and we characterized and compared fecal and oral microbiota. The samples were collected prior to the initiation of any therapy, and then 16S rRNA sequencing was done. And this, we demonstrated that gut alpha diversity was lower in the breast cancer group. So remember, the number of species was lower in the breast cancer group. Okay. Then the beta diversity, which is kind of the composition of the bacteria, was different between the group that had breast cancer or DCIS and the healthy group. And we found that Bacteroides and Enterobacter were more common in the breast cancer group, and that Clostridialis was more abundant in the healthy group. So we found that there was no difference in oral microbiomes between those, both with alpha and beta diversity, so just differences in the gut. And so collectively, studies have shown that breast tissue has a distinct microbiome with particular species enriched in the breast tissue itself, as well as the nipple aspirate, and the gut bacteria of women with breast cancer. And most importantly, the breast and the associated microbiomes, they may modulate therapeutic response. And so they can potentially serve as potential biomarkers for diagnosing and staging cancer. Now, this leads me to my real question. Well, does the microbiome have a role in implant infection? So based on what we know, the microbiome is linked with cancer, and specifically it's linked with breast cancer. And we've also now observed that the microbiome is linked to surgical complications. And so is it possible that the microbiome is actually potentially what's driving these implant infections? And then how does antibiotic administration impact the microbiome? This is kind of like a secondary question. And as well as how does it impact infection rates and outcomes? So in effort to answer these questions, we designed a 2-armed randomized control trial in patients undergoing mastectomy with implant-based reconstruction. And initially, we just included patients who were having a tissue expander placed. So cohort A received 24 hours of antibiotics and then 7 days of postoperative Keflex. Cohort B just received 24 hours of perioperative antibiotics. We then followed patients for any clinical signs of infections for 90 days. And then we collected data on infection rates, as well as different treatment types. These were all of the samples that we collected. So we collected a stool sample roughly 1 week before surgery. The day of surgery, we swabbed their abdominal skin after they did the skin prep. Intraoperatively, we collected a 1 by 1 centimeter segment of breast tissue. And then postoperatively, I use these dual port expanders, which allow you to aspirate the periprosthetic environment. So it's essentially a sterile way to access that periprosthetic space. And then we collected that at 2 time points postoperatively. So kind of at their first visit and then at their second or third visit. And then we also collected a stool sample between 1 and 2 weeks postoperatively. We attempted to standardize the operative details as much as possible between all of the surgeons that were involved. And so all of us used the same type of acellular dermal matrix for every case. We always use Dermacell. All the patients were scrubbed with the chlorhexidine prep and scrub, unless they were allergic. Prior to placement of any tissue expander, betadine was allowed to sit in the pocket for 3 minutes before we irrigated with saline. And then we all did the same postoperative dressings. We used skin glue. They had special nipple huts. They were put in abdominal binders or ABD pads in a surgical bra, and they weren't allowed to shower until postoperative day number 3. All samples were immediately placed in 2 milliliter cryosafe tubes that had been sterilely pre-filled in a hood with DNA and RNA shield. Then all of the samples were stored at one of our collaborators, -20, and we collected them all for batch analysis. It's important with microbiome analysis that you want to look at as many samples as possible, okay? And so our primary aim was to test the feasibility of microbiome sequencing with 16S rRNA methods. And then our secondary aim was to look at the impact of antibiotic duration on clinical outcomes, so rates of infection, rates of implant loss, as well as look at the impact of antibiotic duration on the microbiome. First, I'll go over our pilot study. We wanted to make sure that we could even sample and that things would show up because this had never been done before in the kind of breast periprosthetic space. So we just did 10 patients. 5 patients were grouped into the 24-hour antibiotic arm, and then 5 patients were put in the 7-day antibiotic arm. We had 20 samples that we initially looked at. So looking at the intraoperative tissue sample, as well as the first postoperative aspirate. So everything I'm going to refer to as aspirate means that periprosthetic environment, the space where the breast used to be. And then we used a company, mRDNA. We had initially tried to go with UCSF, but they didn't feel comfortable. We had a microbiome core, but they didn't feel comfortable with or confident that they would be able to extract samples. But mRDNA was the company that we spoke with who felt like they could extract samples. And what we identified was the most common genera were Pseudomonas, Corynebacterium, Phenylobacterium, Acinetobacter, and Staphylococcus. And we detected between 10 and 37 genera in each sample. So we felt confident, this was good. It worked. And we identified 99 genera in total. Now, looking at the clinical outcomes, we had one patient in the 7-day cohort who developed a late infection. So an implant infection after the tissue expander was exchanged for the implant. We treated it with Bactrim. We did not have any culture data because it was treated with antibiotics alone. But we did see that there was a change in between the first and second postoperative aspirate samples based on our 16S rRNA sequencing, where the dominant genera were Burkholderia and Streptococcus, and it changed to Sphingomonas and Pelomonas. We had one patient in the 24-hour cohort who had an infection of the tissue expander requiring explantation. And this was interesting because on 16S rRNA sequencing, we found that there was a change in Pseudomonas from 4.29% in the breast tissue segment at the time of mastectomy to 71.1% at the first postoperative sample. And then later, it's all later because we don't get the 16S and rRNA results until months later, but it correlated with the fact that that explant also grew Pseudomonas. So these initial lessons, we found that 16S rRNA sequencing is feasible on breast tissue as well as that peri-expander fluid. And we found that there was a really wide range of genera that were represented. So as I mentioned, those 5 before, they might be the most pervasive in that breast kind of environment. And we do know that Staph and Pseudomonas, those are the most common organisms that are implicated in implant infection. We also did some kind of background digging, and Corynebacterium and Acinetobacter, those have been reported in the past to cause implant infections. We sometimes identify those in our implant explants. And then Phenylobacterium also causes cutaneous infectious granulomas. So they all have the potential to be pathogenic, yet they exist without being pathogenic. So we found that our microbiome data did parallel our culture data, but we also found that in some samples, there was consistently dominant genera, and there was a shift, but the shift didn't necessarily result in clinical infection. And so the dominance of one genera alone does not predict clinical infection. There's something about the interplay of the bacteria that does. So next, we expanded our study and we made some protocol modifications. So at this point, we then expanded to 40 patients, so 20 per arm. And then we let patients choose their antibiotic arm because we found that some patients weren't wanting to enroll because they didn't want 7 days or they didn't want 24 hours. And so we let patients choose their arm. And then we also included direct to implant patients. Now, the direct to implant's a little bit trickier because now we are not aspirating to get truly a sterile sample, but we didn't want that to limit patients who potentially could collect that breast tissue, skin, and gut. So ultimately, with those 40, we were able to use 37 of the patients who had intraoperative and postoperative aspirate samples. 62% had invasive cancer, 16% had DCIS or LCIS, and 22% were undergoing this for prophylactic reasons. The top 5 represented genus are very similar to that initial 10 patients. It's just Burkholderia now popped up instead. And so shown here are a few of the top represented species in each sample. And at the time of surgery, the most represented genus in the breast, which is the kind of schematic on the top, so that varied significantly between cancer patients, in situ patients, and non-cancer patients. But this was not true among the first postoperative samples. So intraoperatively, Pseudomonas was the top represented species in 50% of the prophylactic simple mastectomies or sample, and then compared to 43% of those who had invasive cancer and only 33% of those who had in situ. And then postoperatively, Pseudomonas was represented in only 12.5% of those prophylactic samples, compared to 43% of those with invasive cancer and almost 67% of those with DCIS. Okay, so next we're going to talk about mean relative abundance. Okay, mean relative abundance is a term that's used to describe the percent of one genus within a sample. And through 16S rRNA analysis, we are given the counts of each genus within a sample. And so then you can calculate the percent relative abundance within that. And these were often compared between the intraoperative and postoperative samples. So now looking at the mean relative abundance between the intraoperative tissue samples and the first postoperative aspirates. So when we compare invasive cancer and DCIS, we're just going to group that now into cancer, okay, versus prophylactic. We found that the mean relative percentage of each signal in the sample showed no difference for Pseudomonas and for Staphylococcus. But at the time of surgery, there was a significantly lower rate of Acinetobacter and Burkholderia that was present in the non-cancer patients compared to cancer patients. And then this changed postoperatively when now there was a higher percentage of Acinetobacter in non-cancer patients and no difference in Burkholderia. So a lot of this, we're seeing these trends, but not quite sure how do we interpret them. And so now I want to take a total step back and we're going to delve into the alpha and beta diversity of all of these samples at the time of mastectomy. So first, we're going to look at tissue samples, okay? And alpha, I'll remind you what alpha and beta diversity are, but so in this chart, we're looking at the alpha diversity. So that's the total number of species that are represented in each sample. And we're comparing antibiotic treatment length. So the blue is 24 hours, the brown is 7 days, and that's consistent throughout, okay? So, and we're also looking at patients who have surgery for prophylaxis, which is the image on the left, versus cancer, which is the image on the right. And we found that antibiotic treatment had no influence on Shannon diversity of tissue samples, which is good, what we expect. Like it shouldn't, they haven't even gotten antibiotics yet, okay? But we also found that there was no difference between cancer and prophylactic patients of the tissue samples. Now, I do want to point out the tissue samples, we always took it was very far from where the cancer was. Okay, so if the cancer was upper inner breast, we took a tissue sample from the lower outer breast. So we tried to get a sample that was very far from where cancer was. And I'll show a lot of these. This is a taxobar plot. A taxobar plot shows the 10 most abundant genera in the tissue samples. And I'm sorry, it's very small. I couldn't make it. I tried to make it bigger. I couldn't figure out how to make it bigger. But maroon is Pseudomonas and orange is Staphylococcus. So you can see that nearly like the maroon and the orange dominate almost everything in this taxobar plot. And so then we looked at beta diversity, which represented the number of unique operational taxonomic units between samples, okay? And we found that there was no difference between the antibiotic cohorts, which is good. That's what we expected. But there was also no difference between cancer and prophylactic patients. So now we're going to look at the skin swabs. And just as a reminder, we took it from the abdomen after they'd done all of their prep wipes in the preoperative area. So we found that, same thing. The antibiotics are the blue versus the brown and then prophylactic versus cancer, okay? So we found that there was no difference in alpha diversity between antibiotic cohorts, which again is expected. They haven't been treated with antibiotics yet, as well as no difference between cancer and prophylactic patients. And again, we're going to look at this taxobar plot, but this time reminding you it's of skin. And Staph and Pseudomonas are again the maroon and the orange, and they are the most commonly observed. But this time we also see that there's more yellow, and yellow is Corynebacterium. Next, when we looked at the beta diversity between the samples, we found that there was no difference between antibiotic cohorts, as well as no difference between cancer and prophylactic patients, okay? But now we're putting in our control samples. So now we're gonna look at tissue samples, skin samples, and control samples, and we're gonna normalize them against each other. And we confirmed that there was no significant difference in alpha diversity by sample types or by antibiotic treatment. But now when we're looking at the beta diversity, so the kind of composition of bacteria between breast tissue compared with the skin swabs, which were again were normalized against the controls, we found that the communities from the tissue and the skin were significantly different from control communities, and that the tissue and the skin samples were also significantly different from each other. This makes sense. We would expect the microbiome of the skin to be different than the microbiome of the breast, but for us, this was all confirmatory. This was all telling us, okay, what we're seeing is real. So next, we looked at postoperative aspirate samples between the various groups. So when we looked at alpha diversity, and this is between the 24 hours and 7 days, we found that the different antibiotic treatment length led to significantly different alpha diversity in the breast aspirate samples, with the longer antibiotic duration resulting in decreased alpha diversity. So this is in that kind of periprosthetic environment. We found that the disease states, whether it was cancer versus prophylaxis, did not have an influence on the alpha diversity of the aspirate samples. And also the interaction of the antibiotics with the disease state was not significant. Now, when we compare the different postoperative aspirate time points, we found that antibiotic treatment length showed a significant difference in Shannon diversity in breast aspirate samples. This is a very busy slide, I'm sorry, but it's looking at the taxobar plot of the most abundant genera in the aspirates at the various time points. This is a ton of different time points, but my point is that the most common genera represented continue to be Pseudomonas, which is in maroon, and then Staph, which is in purple. And when we examined the beta diversity between the aspirate samples, we found that the overall antibiotic treatment had no effect on the bacterial composition of the breast aspirate samples. The time points do not show significant differences in composition between the first and second sampling for either length of treatment. However, we did see that the bacterial composition is significantly different based on disease state. So finally, the last kind of session that we'll review are the gut samples. And we found that the alpha diversity showed significant differences between pre- and postoperative samples in both antibiotic arms. These findings were more dramatic, however, in the 7 days. So the 7-day had a significantly decreased diversity and abundance of bacteria. So this taxobar plot is showing the most abundant genera in the pre- and postoperative gut samples. And the most abundant genera that you can see throughout the samples is red, and red represents Bacteroides. So now when we're looking at the beta diversity between pre- and postoperative gut samples between the 24-hour and 7-day groups, we found that there was no difference in beta diversity. But we did find that the cancer group was significantly different from the prophylactic group. And it appeared that the patient was actually the primary driver of that microbial community. And so putting this all together, what we found, first, let's compare the cancer versus the prophylactic patients, okay? So cancer versus prophylaxis, we found there was no difference in skin or tissue alpha or beta diversity. But when we look at the aspirates, so that periprosthetic environment, we found there was no difference in alpha diversity between those cohorts, but we did find that there was a significant difference in beta diversity. When we looked at the gut between the two cohorts, we found that there was no difference in alpha diversity, but again, we found that there was a significant difference in beta diversity. So there's some kind of relationship between that periprosthetic environment and the gut. When we now compare the groups who received 7 days of antibiotics versus 24, so not really including cancer into this analysis, okay, we found that there was no difference in skin or tissue, which is confirmatory. We did find in the aspirates that there were significant differences in the alpha diversity, but that there was no difference in beta diversity. And that in the gut, that there was significant differences in alpha diversity between pre and post-op, but there was no difference in beta diversity between the groups. And so what can we say? Well, now we can say that beta diversity is significantly different between skin and tissue. We can say that the gut alpha diversity is significantly different pre and post-operatively in both cohorts, and that there were more significant changes in the 7-day cohort compared with the 24-hour cohort. Gut beta diversity is significantly different between cancer and prophylactic patients. And the difference in gut beta diversity seems to be driven by the patient rather than by antibiotics or surgery. So what I learned is that we had massive amounts of data that essentially I will never be able to understand, okay? So you need someone who really understands microbiome science that you can collaborate with. And this has been a many year-long process, but so initially we'd worked with mRDNA, but these collaborations were then with UC Irvine. And UC Irvine has a pretty incredible microbiome science team, and we have been working with them for the past couple of years. You need controls, because controls is what allows you to normalize everything and ensure that what you're seeing, because it's amplification of such small amounts of bacteria, is real and not just contamination. So the controls are critical. Not all of our samples amplified, and we don't really know why. We have kind of become much stricter with how we do everything, but that's a potential flaw. The 16S RNA sequencing takes a long time, like months. So 16S RNAs, we send it to the lab. We won't get the data for months, but analyzing the data takes even longer. And so the group, they had been working diligently, and it took them about 6 months to come up with this data. And finally, there's a complex interplay of many factors that we definitely don't understand. So what's going on now? Well, we have continued to enroll patients. We have 173 patients that are currently enrolled in our trial, and we have 133 patients with outcomes data. So 65 patients are in the 7-day cohort, 68 patients are in the 24-hour cohort. And they overall have very similar demographics. The 7-day cohort has a slightly higher BMI, but the number of patients who have cancer versus prophylactic are similar. And the patients who have received neoadjuvant versus no chemotherapy are similar. When we're looking at their surgical details, the indications for surgery are similar between cohorts. Whether they had direct to implant versus tissue expander reconstruction is similar. The plane of the reconstruction is similar. But now let's look at the infection outcomes of these patients. So this is comparing the 7-day cohort and 24-hour cohort. And what we found is that the overall infection rate is comparable between the two groups. The implant loss rate is comparable, and the day to first infection is comparable, although it looks like maybe slightly longer in the 7-day cohort, but can't say anything. But now let's look at the rates of infection based on cancer status. So based on patients who had mastectomy for therapeutic, and this is on a per breast thing, so a mastectomy for a therapeutic reason versus for cancer. And we found that those patients who were having a mastectomy and implant-based reconstruction for cancer had significantly higher rates of infection, so 28% versus 7%. They had significantly higher rates of implant loss at 19% versus 3%. And the time to first infection was significantly longer in the cancer patients. So in conclusion, in this randomized control trial, we found that there was no significant difference in clinical infection rates between patients who received 7 days of antibiotics versus 24 hours of antibiotics alone, as well as no difference in the rate of loss of reconstruction. But I really feel that a longer course of prophylactic antibiotics is not protective, right? Antibiotics do not prevent infection. And so I think we should reevaluate the use of prolonged antibiotics following mastectomy with implant-based reconstruction. And really, we should reevaluate the use of prolonged antibiotics in any surgery. And so, as I said right now, we enrolled 173 patients. Our goal is to get to 200. We now are collaborating again with the UCSF Microbiome Core. We really are trying to keep everything in-house, and now the core feels that they have the capabilities to do the proper assessments. And we're currently extracting and analyzing the data for our next 87 patients, 156 breasts. And so what have we learned thus far? Well, we know that bacteria are present in that periprosthetic environment. And that space is not possible to be sterilized. It doesn't matter if you do a local administration of antibiotics, the bacteria will still exist. And so we should not focus on eliminating bacteria. Rather, we need to figure out how to optimize the balance of microorganisms. And I think that this could be applicable really in any surgery. And of course, as we're doing this, questions lead to more questions. And so as we've been kind of going through the data and analyzing things, I'm saying, well, what are the implications of cancer versus prophylactic surgery? Why are we seeing such dramatically higher rates of infection in these cancer patients? And how can we correlate that with what we're seeing from the microbiome perspective? How does neoadjuvant therapy impact the microbiome? Is it possible that these different chemotherapy regimens have a more profound effect? What are the immunomodulators doing? And how does the timing of surgery and neoadjuvant therapy relate? Like, is it possible maybe we aren't waiting long enough? Maybe we actually need to wait a little bit longer. Finally, and we've started to work at this at UCSF and really more in our DCIS patients, but can we modify the microbiome preoperatively in a favorable way? Some of these studies have shown that preoperative administration of probiotics can actually promote better bacteria. So is this something that we should look at? Should patients be treated with different perioperative antibiotics? Like, at some point, ideally, we can provide this personalized medicine where we will understand the different types of bacteria that people have and instead target how we treat them differently in the perioperative setting. So with that, I just want to thank everyone. I have had an incredible research team, Laura Barnes, Nisha Parmeshwar, Alex Knox, Eileen Gonzalez, and next I'll have Melinda Len. So I've had this series of residents who have really been incredible with this. I also have many medical students who work with me, and I've had a series of breast care center interns who are pre-medical students who are really incredible. And right now I have one named Michael who's with me for the past 3 years. We've also received funding through our Plastic Surgery Foundation, through the NIH, through T32 grants, and through the breast care center. And with that, I always got to show a picture of my wonderful husband and beautiful 3 children. So thank you all. I welcome questions.
Thank you so much for your presentation. I had one question about some of your data. It shows that there's a certain number of patients, but then you're separating them into breast numbers. So presumably some patients have bilateral mastectomies and you're counting them as separate instances. Have you compared, when you're talking about the, it might be just the patient and their tissue and their microbiome, but have you compared right to left or within the patient?
We have not. You're speaking specifically about the bacteria, looking at the microbiome. We have not, and it actually becomes very difficult to compare one breast. You want to be looking at the whole group when you're doing these analyses. And so with our initial analyses, we did, but that's not really true like microbiome science. They don't want you to look at it on a per patient level yet. Maybe at some point we'll be able to be more specific, but instead they're looking at it as groups and changes in groups and trying to put patients into groups versus single them out. And so with that initial pilot trial data that I showed when we looked at it at a per breast level, that technically is not what you're supposed to do when you're looking at all of the bacteria. Maybe someday. We just aren't quite there yet.
Dr. Piper, thanks for that great talk. It's a cool take on a problem that a lot of us deal with very frequently. As someone who's in the UC system, I'm sure you know Chris Reed and his proclivities for antibiotics in the pocket. Thoughts on how obviously that's going to disrupt specifically the microbiome of that periprosthetic environment you talk about, and just the implications for that. I mean, he, reports and publishes a phenomenally low rate of tissue expander infection. So Jeff, just curious about your thoughts on that.
I've talked with Chris a lot, and there's also Raheem Nazarali at Stanford who uses the antibiotic discs. The problem with or I shouldn't say the problem, those only exist for a short period of time, right? So if you use an antibiotic disc, it has to be removed at the time of tissue expander to implant exchange. You can't leave an antibiotic disc in place. So it theoretically is just covering while it's there and eluting antibiotics. If you're using antibiotic beads, they dissolve and they're really only effective for maybe the first 30 days. And so for me, that's not the infection that I want to understand so much. It's the late infections. And I have mixed feelings about that local delivery of antibiotics. I mean, I don't think antibiotics should be used for prophylaxis. Like, they should be used to treat infection. I think when you use them for prophylaxis for extended periods like that, it's just going to create an environment that's very different. Your body will get smarter and adapt. And I know they publish their data, but the thing is also, like, people only publish 30-day infection outcomes. People aren't publishing infection outcomes for 3 years. We see plenty of patients who come in 2 years later, infection. So, I mean, it's an interesting thought, but we know that you aren't ever going to totally sterilize it. Mm-hmm.
If there was predominant species. What type of infections, microorganisms, are you seeing in the late stages? Are they similar? Are they different?
The problem with late infections is that you are often not able to capture anything on culture data, because when someone shows up with a late infection, they're often getting antibiotics for an extended period of time. So you're only really getting culture data when you're taking them for explant, and that's usually after they've been on antibiotics for like a minimum of 72 hours. So I would say I have had some. I tend to, when we've had late infections, sometimes we're seeing Proteus, sometimes we're seeing MSSA. MSSA creates this biofilm. And so patients can linger with an infection I've had patients linger with an MSSA infection for months. And so sometimes still you'll be able to capture that because there's such a thick biofilm that the antibiotics haven't penetrated. But again, if they've been on antibiotics for that long, you aren't totally sure if that's the only causative organism.
Thank you. That was probably the most fun.
Sorry, Connor. Well, the thing is, Pseudomonas exists everywhere, though, right? It was the predominant organism, like on our skin, in our breast tissue, it wasn't in our gut. I mean, it's present. I should say it's present everywhere. And in some patients, it's like makes up more than 50% of what the predominant organism is. So I don't necessarily think that it's even something we should target, because in many people, it's probably normal and healthy and it coexists. But I think there is something to say for probiotics beforehand. It's just trying to figure out like what's the ideal probiotic and duration. But potentially you can change your gut. I don't know. I don't think that targeting Pseudomonas preoperatively would necessarily make a difference, because it exists. I mean, it's everywhere. It's everywhere in your body. We have not compared yet the direct to implant it's two-stage, but anecdotally, I believe that direct implant has lower infection rates, but I can't say. I haven't looked at it. But yeah, I believe that the repeated expansions, even under sterile technique, there's something about that. It causes this micro trauma to the skin over and over again. Mm-hmm.
I have a comment from the chat here. This is from Dr. Calhoun, one of our breast surgeons. It isn't really a question, but more of a thought. You mentioned delaying surgery for neoadjuvant patients to allow the microbiome to recover. We have to balance that with timing about worsened outcomes if time to OR is delayed. Interesting.
Yeah. I mean, but like, do they need to go? Usually we give them a window of 4 to 6 weeks. Well, should we maybe wait more like 6 weeks versus 4 weeks? I mean, we don't know. And we kind of do it whenever it fits, as long as it's within that 4 to 6 week window. But potentially, could that make a difference waiting an extra week or 2 weeks without compromising their cancer care? I mean, it's just a question.
Think about other procedures and specialties that are heavily invested in
non-autologous implants, total hip arthroplasty, spinal hardware cranioplasties, and things like that. Are there parallels that you've seen, in those other kind of specialties and anatomic areas that are finding a link to, microbiomes, gut microbiomes, and things like that? And not to make you get too far out over your skis, but what do you see are maybe the implications from your work for some of those other things like cranioplasty implants and some of the delayed infections with that?
Yeah. So I think that breast implants have such high infection rates that it's much easier to study those compared with implants really anywhere else in the body. They're so much lower. Anecdotally, I'll say with the cranioplasties, oftentimes when we're seeing infections with those later on, they're with things that typically are not what we would consider pathogenic, things that live on our skin that become pathogenic. And I don't know. I feel like it has the potential to study in many different environments, but I think everything is ultimately linked to the gut. I think that, I have this theory that I tell my patients, I'm like, it's just my theory, but I think that, we develop leaky gut. Maybe you eat some food that irritates your stomach. You develop a little bit of systemic inflammation. Now you have maybe potentially a higher level of circulating bacteria that can seed your implant or your cranioplasty, your knee. And so that's actually what I think happens, because most times when patients have an infection so laid out, there's nothing, there's no inciting event. We think, oh, well, did they have a spider bite like 2 weeks ago that maybe did that? But realistically, yeah, no, I think that your body normally has bacteria that are traveling throughout all the time, and you're just in this normal level homeostasis, and something makes it go a little bit out of whack. And now you have your bacteria that are normal that suddenly kind of take over, and they'll seed someplace that doesn't have normal circulation.
We have time for just one last question. I have one in the chat that I'll forward to you later, but yeah, one last question.
Thanks. This is a good question to end on, I think. You have really shown that we as surgeons are in such a unique position to ask really insightful and important questions. And I think because we have a lot of trainees here, maybe you can speak a little bit about the pathway to becoming a surgeon scientist and how, because this work has got to be incredibly expensive you're working with these microbiome teams, you're working with a company that needs to get paid, right? It comes down to dollars and time in a way. And so from where our trainees are starting, where they're picturing what their career might look like, and often are discouraged that, the surgeon scientist is really not possible anymore. And there's really, it's such a hard path to success. What advice do you have about becoming a successful surgeon scientist and the major steps that you see as kind of how to get there?
Pair yourself with good residents. I mean, I had research funding when I started that I kind of negotiated for and renegotiated for. And then we apply for tons of grants. I mean, and most grants we don't get, but maybe we get like 10% of the grants, but we apply for a couple grants a year and just hope that something pans out. We're kind of in a tough spot now with the grant funding is just very limited. So I'm not totally sure what's going to happen. And that's why I said, I'm going to hit this 200 and then stop, because the cost is prohibitively high. I do think that building your team is so important. And it's the residents that I've had work with me. I mean, they've been truly inspiring and they motivating. And then I've had this crop of medical students every year who just are so enthusiastic that they make you want to keep doing it. So I'd say if you get a good team of people, then it makes it much more feasible. If I was trying to do this on my own, it would have been impossible because the person's collecting all the samples doing this. I mean, everyone's bought in, right? Like our nurse practitioners are all bought in. They know the patients who are on the trial. All of our breast surgeons are bought in, all of our plastic surgeons. And so everyone's kind of on board, which is huge.
Thank you so much.